Okay, so welcome everybody. I'm very happy today to introduce Dr. Kara Patterson. She's a physical therapist and a researcher at the University of Toronto. We're super excited to have her here today to talk with us. She's a graduate of Queen's University, where she got her degree in physical therapy. She did practice clinically for a while as well, both in Canada and the US, before returning to Canada to pursue her research graduate studies at the University of Toronto and then later on at McGill as well, right? And
yes.
Yeah, and she's currently an associate professor at the University of Toronto, where she conducts research around gait dysfunction in populations with neurological injury, especially stroke. And she is also, I'm happy to report, I just noticed this on the internet this morning, she's the 2017 recipient of the Ontario Physiotherapy Association's Innovation and Advancement Award, which is an award that recognizes physical therapists who have been trailblazers, nonetheless, within physiotherapy and who advance the science of the profession through innovating approaches in clinical practice, research, technology, and education. So, wow, congratulations. That's pretty awesome. What a great honor, and I'm sure that the reason that you won the award is the same reason I'm super interested in the research that you do. So thank you again for joining us today, and we're excited to get into this. So why don't we talk about that? Tell us about some of your research, and you've done this stuff that I mentioned around some gait dysfunction, but as well you've got some exciting stuff that you're looking at around interventions as to how we might address some of those gait dysfunctions. So can you give us a little bit of a brief background on that?
Yeah, sure. So the ultimate goal of my research program is to improve walking and balance in people with neurological conditions. Specifically to help them be more independent and improve quality of life, because if you can't get around independently, then it pretty much limits everything else that you can do.
Yeah.
And so my work is largely focused on walking with some interrelated research related to balance, because those two things are so closely linked. The things that I'm most interested in to date, a lot of the research, particularly in stroke walking, is focused on speed. Let's get these people walking faster. And certainly gait speed is important. You need a certain amount of speed in order to do things like the typical example is crossing a street in time before the street light changes.
Yep.
But clinicians spend just as much time looking at the gait pattern and how symmetrical is the gait pattern. Yeah. Are they actually close to what a neurotypical gait pattern looks like? Because we know that that's important as well.
Why do you think, I'm sorry to interrupt, but why do you think that that's important? You know what I call that? I call that moving beautifully. So why do you think that we spend as much time looking at that? I totally agree with that, but why do you think that that's important?
Yeah, I think it's important, first of all, because it's important to our patients. So there's a very there's a very highly cited study by Mohannan and co-authors done a long time ago, where they actually went into a stroke rehabilitation unit and they asked people with stroke, what's important to you about your walking? And sure enough, a lot of them selected speed, but just as many of them selected appearance. So first and foremost, it's important to the patients that we treat. But also, I think intuitively we know, whether or not it's taught explicitly when we learn about the gait pattern, we walk the way we do for very specific reasons. We are very symmetrical in the way we walk because it's the most efficient way to walk. And it also distributes load across both limbs in an equal way. So I think it's important to worry about the gait pattern for those very specific reasons. If you're walking asymmetrically or you're loading one limb more than the other, it's going to be more tiring to walk, and also it could lead to cumulative effects down the road, like joint degeneration and pain.
Right. Yeah. Yeah, awesome, good. So you've looked at some of these other qualities of gait besides speed, and specifically I've noticed in your research that you look at symmetry, right? So the asymmetries that people with neurological injuries are sometimes dealing with. And you've also looked at some interventions as well, which I thought was super cool. Can you tell me about that a little bit as well?
Sure.
Yeah.
Yep. So the most recent thing that we're looking at is the use of dance classes to improve gait and balance. That was my initial intent. I've danced personally all of my life, so it was a bit of a selfish act of trying to incorporate something I love from my personal life to make work even more enjoyable than it already is. dance. But also because I know what dance can do. Dance is a very challenging exercise, but when people are doing it, they don't think of it as exercise. It's just fun.
Yeah.
But it has aerobic benefits, and it also challenges balance. And so I thought, well, that might be a great way to make exercise more fun, but also have these specific benefits. But if it's fun and you can do it in the long term, then it's even, you're kind of getting 2 for 1 deal.
Yeah.
Plus, there had been so much done in dance for people with Parkinson's disease, but we did a systematic review looking at whether or not dance has been used for other neurological conditions, and there's actually very little work done.
Yeah.
So we just ran a feasibility study. So there was no control group, but we just wanted to see if we build it, will they come, kind of thing. So we wanted to know, can we do this dance class? Will people be interested? Will they like it? And then we did some limited testing to look at efficacy. Is there some indication that this could improve balance and gait? And very much to our pleasure, we found that it did. It improved we used the mini best test because the Berg balance scale, as I'm sure most physios know, has a pretty big ceiling effect. And because our people in our studies were people who had been living in the community and presumably would have scored pretty well on the Berg, we wanted to challenge their balance a bit more.
Right.
And then we also looked at the spatial temporal parameters like gait speed and symmetry.
Okay.
So gait speed did improve. So we're comparing from the beginning of the dance program to the end of the program, and gait speed did improve. Symmetry seemed to improve, but not enough to be statistically significant. But we think that maybe if the dance class had gone a bit longer, we might see that statistical movement. And balance improved, which interestingly enough, the dynamic component of the mini best test is where they showed the most gains. So being able to walk and do something else at the same time, which given what dance involves, is not surprising.
Yeah.
But I think what surprised us the most, or we didn't necessarily expect it, was this intense social connection that the group formed with each other.
Yes.
They really enjoyed it, and it had so many other psychosocial benefits that now we're interested in exploring too. So, as I mentioned, the sense of community and this idea that they form this intense connection, because stroke can be quite an isolating event. After you go home, most people with stroke report feeling socially isolated. And even our dance participants said, before this study, I was just at home sitting on the couch every day, and I didn't have anything to do, and now I look forward to these days. Yeah. And the group actually ended up forming their own Facebook page just to stay in touch. Yeah. And I think, but although I'm not involved anymore because it's their personal thing, but I'm pretty sure they were trying to organize a reunion dance class.
Awesome.
And then the other thing that I thought was great is a lot of them would express, it increased my confidence. So not just do I feel like I can move better, but I also feel more confident in my ability to move, which is another dimension that's not necessarily directly associated to impairment. So people can have no confidence or little confidence, but have pretty good movement, or the other way around is have lots of confidence, but not so good movement. And when those two things don't match, that's an issue. So if you can impact both movement itself as well as confidence, then you're kind of getting a bonus there. Yep. And then the last thing that I really thought was profound is that they enjoyed going to a class where they weren't a stroke patient; they were a dance students. Yep. And I think that was a great benefit of the dance class that we hadn't anticipated, but we're happy to see.
So there's so many things that you've just articulated in that sort of elegant recap of that research study, a number of which I couldn't be more on board with. The first of which is that idea that there has to be an element of joy in exercise, and especially rehabilitation type exercise, but any exercise. Doesn't matter if you're doing it here or you're in good life in the gym, and it has to be fun. If it's not fun, we might as well throw our hands up and not do it. Yes, yeah.
So much of our day doing stuff that is not necessarily fun. You're like, oh, okay,
yeah.
So why should you make exercise be another? Don't add exercise to that list. Find something that you find enjoyable.
Yeah, we have to laugh while we're doing it, right? So I love that. I think that's extremely powerful, and I don't think that that's sort of airy-fairy stuff at all. I think that is real and powerful. I really, really like that. And also this idea of confidence being an important outcome from this intervention. Part of the reason that I go on and on with my clients about beautiful movement is that moving beautifully brings confidence. It's one way that you can really project yourself in a powerful manner. And it has an effect both on the way that you look at yourself, but also a real effect on the way that other people look at you. So I could not be more on board with that. And I think that we don't push that message enough in rehabilitation and in physical therapy. The aesthetics are important.
Yes.
Right? It's not superficial.
Yeah, it's not superficial. You're right, and maybe we need to come up with a different term than aesthetic. I think that's such a loaded word. Everybody thinks that means superficial, and it's not. You're right, and the impact it has on how you feel about yourself and how others view you is huge. I like that. Moving beautifully. That's encompasses it all. Yeah.
Pretty good, huh? Yeah. I put it in the same. I put it in the same category as, but more powerful than wearing a beautiful suit. You feel great when you dress nicely or in a way that makes you feel good. And I think that movement and posture are that on steroids. So I love that. Yes. And then the last thing that you mentioned that I really sort of tuned in on there was this concept of treating patients not as patients, but as athletes, because that's what they're doing. If you're doing physical activity in the pursuit of a specific physical goal, guess what? You're an athlete. And we need to...
Sport is life.
Yeah, it is. And I think this is... We all as human beings get to access that part of ourselves. And when we don't, either by external perception or internal perception, that is, I think, a tragic loss. And one that I think, again, we in the physical therapy community have a powerful lever to address. So yes, you do that.
Yeah.
All right.
I was just talking about being an athlete or not. Some of us don't think of ourselves that way. I was just at a one-day conference on traumatic brain injury.
Yeah.
And the kind of keynote closing speaker was Adam Van Koeverden, the kayaker.
Yeah, gold medalist, multiple-time Olympic medalist. That's right.
Exactly. Yeah. And it was great because he was talking about his journey to finding his sport. He said, I was terrible at everything. I tried every sport through high school and grade school and didn't make any team. He said, I didn't grow up wanting to be a kayaker like a kid does. Nobody's watching kayaks on the, on the TV.
Kids will have their kayak cards lined up in plastic to trade, right?
Exactly. But he ended up trying everything and then eventually finding where he fit, and it happened to be kayak because, as he said, it turned out his skill was endurance. He could do something for a long period of time, and it really struck me that that's true of every patient. It's like you just haven't found what it is that you motivates you or that you're good at yet. But that doesn't mean you don't have something. You just haven't found it yet. And I think far too often people get discouraged and quit before they find whatever it is. And it doesn't have to be a sport. It could be dance. It could be music, or something else. But yeah, as physiotherapists, I think that we can facilitate that. We can help people explore their movement and find what it is that they're good at.
Okay, great. So what do you think it is about dance that generates these types of outcomes? I know you sort of touched on this, but why dance? Why not another type of activity?
Yeah, that's a great question. And I should be careful to say that I don't think dance is going to cure everybody.
Yeah, of course.
For everybody.
That's really you think, yeah, of course.
But my bias. However, having said that, I'd say the majority of people do enjoy dancing. And if some of the stuff that I was reading in preparation for writing this grant, and I'm doing this study from a scientific perspective rather than as a dancer's perspective, a lot has been done. If you think about it, across the world, across every culture, everybody dances. It's a human worldwide activity. And so there's been a lot of theory and some work into this of why do we do that. And some of what that revolves around is this idea that our bodies are kind of wired and our brains are wired to synchronize to some sort of rhythmic cues. So that could either be when we, so for example, it's why armies practice marching, because rhythmic cues of moving in sync with other people to marching creates a feeling of social cooperation and feeling a part of the group. And I think dancing does that as well. Any exercise obviously is going to be good. So yoga is another example. Pilates is another example. I think those all can provide similar benefits to dance. But I think what dance has that maybe some other forms don't is this idea of synchronized movement both to the music as well as to other people. So you get the social aspect by synchronizing your movement to other people. And then there's a whole other field of research that's looked at the connection between our auditory system and our motor system.
Right.
And you can actually prime the motor system by providing a rhythmic cue, either in music or a metronome. And I think that's an added benefit of music, is this idea that I'm linking my movement to music, which presents both a cognitive challenge, but also a facilitation effect.
Right. So this idea that there may be some alternate pathways sitting there in our brain that we can use to access those motor patterns, like, for example, walking, that we can access through music, which we get in dance.
Yes.
Go ahead.
Add on top of that music itself is motivating. They found I don't know about other people, but me personally, if I forgot my iPad at home, I'm not going to the gym.
Right.
So
right.
music provides that extra motivating factor, and they have shown that people's motor performance when they're playing music that they like is actually improved as well. So there's just all kinds. I think it's a multifaceted benefits.
Okay, so we know that the outcomes are there. Are we getting anywhere on figuring out what the mechanisms are? And how do we figure that out?
Yeah, that's a great question.
Yeah.
I'm hoping to do that. I don't know the next kind of branch of this piece of work that we're doing. I think we start by measuring actually what happens in the dance class, which is a challenge because moving creates artifacts in the types of measures that we like to use. So when you talk about mechanisms, if you're looking to measure neurophysiologically, you need to think about using electromyography sensors to measure muscle activity, or electroencephalography sensors on the skull to measure what's going on in the brain. But all of those things are sensitive to movement, so it presents a bit of a challenge.
Right.
However, it's not to say it can't be done. And the other thing that we're going to start off with is by measuring just movement. So using accelerometers, which is similar to what's in a Fitbit, but we're going to use research-grade accelerometers that we can measure into a computer and measure everybody's movement all at once, so we can track what each person's doing in class.
All at once, as in it matters what the group is doing? I don't.
Yeah.
Yes.
So each person, this is where we're hoping to go with this. Each person's going to wear an accelerometer, and each one of those accelerometers sends a signal to our computer.
Yeah.
So we can track the frequency or the rhythm of their movements. But because it's all going into the same recording, we can then see how in sync everybody is with each other.
Whoa! And why would you think that would be important?
I'm wondering whether or not we can link how well individuals sync to the group to how much benefit they derive from the dance class.
How cool! No wonder you're winning all these awards.
We haven't done it yet, but that's where we'd like to go.
Okay. Wow, I look forward to hearing about how that proceeds. That is a really nifty idea. I'd never considered that. That's great. Okay, cool. So do you think that, first of all, we talked about how, a moment ago, okay, great. So we as physiotherapists, we get to help people access some of these wonderful levers that are useful in affecting how you look at yourself and how you interact with the world. Great. But do you think you have to be a physical therapist to deliver this type of an intervention, or can it be, more in the community, so to speak?
Yeah, that's an excellent question. I think the model that we used for our dance class that we just conducted last year was a person who has extensive dance training, but also works with people who have disabilities. So
right.
I think I don't think it has to be a physiotherapist, but I think it has to be somebody who has training and understands different disabilities and knows how to adapt to accommodate those things. Mm-hmm. The dance instructor we used actually did do some training in rehabilitation, was not a physiotherapist, but had some training. And then the people who volunteered in our class were dancers who were looking to branch out into the dance therapy profession.
Right.
So no, I don't think it has to be a physiotherapist, but I think there has to be some training. So the TIME program, which was developed by Joanne Howe and Dr. Nancy Selbach has done some great research on it, has this train the trainer approach.
Yes.
And I believe Dr. Ada Tang at McMaster is doing something similar with trying to get aerobic training. So TIME program is, I think, more of a circuit training class, and then the stuff that Dr. Tang is doing is related to aerobic conditioning. looking at this, can we use existing infrastructure in the community like the YMCA, but then train the trainer? So you have a physiotherapist who's providing this training up front, and then perhaps even monitor. I think with dance, there's this unique combination, though. I don't think it can be necessarily just an athletic trainer or a recreational therapist. I think it needs to be somebody who understands dance and the art form as well.
Yes.
So we're looking at a very specific skill set.
Yeah, that might be as important if, I mean, there may come a point where you reach a critical mass of sort of awareness in the world of not just rehab, but fitness in general, that there's a lot of people out there who accumulate that sort of skill set that to lead a class like that. As well as the general population sort of understanding that this is a road that can be gone down to sort of self-therapy. It's like self-medicating, but way better. Okay, very good.
Yeah, it's funny you say that. I just saw somebody on Twitter quote something about, I think it was somebody from Australia said something about, look at all the effects that exercise does. And if this was a drug, we would call it a miracle drug. We think it was a miracle, but because it's exercise, we're like,
Well, that's why we get back to this thing about joy, because exercise is not hard to do, but it's also very easy to not do. Yes. So there has to be a lot of as many different factors as we can introduce into that sort of motivational basket, the better. So that joy part, which is where dance has that huge advantage over, say, lifting weights. Nothing against lifting weights. I think that's fantastic too. Yep. But I do think there's that joy. Sorry, go on.
No, sorry. Some people do get joy out of that.
Totally. Absolutely. And personally, I think that lifting weights can be a very mindful and meditative and peaceful activity as well. I don't think it's enough cred for being a meditative activity. But that's another interview topic completely. Would you call yourself a clinician? Would you call yourself a researcher? Or, like, when someone asks you, what do you do? What do you say? Because you're a physical therapist, you're a professor, you're a scientist. How do you answer that question?
I usually use all those terms, I guess. I think.
Do you practice clinically?
I do not practice clinically at the moment. That's always been a bit of a pull for me. But the reality of my life at the moment, at this stage, is I don't have the time to do both.
Okay.
And be good at both.
You have practiced in the past, though.
I have practiced in the past, yes. But to be honest, research was always kind of where my heart was. I like the profession and I like what the profession does, but I think my skill set and my disposition lends itself better to contributing to the profession through research rather than clinical practice. So I wouldn't call myself a clinician in the sense that I don't currently treat patients in clinical practice. Maybe a clinician researcher, that tends to be the term of some of the research funding that I applied to. So,
okay, that's good.
So we'll go with that.
And you say that you had research as in your head and perhaps your heart as the way that you might be able to contribute to the profession and to the world. So as you were practicing as a clinician, what led you from that clinical practice to the research? Did you want to get some experience and then bring that back to the research world? How did that happen?
Yeah, absolutely. So I got into the Queen's program and enjoyed it, and had always been interested in research. And I had worked for a summer as a research assistant at the Baycrest Center, actually, before I went into the physiotherapy program. And actually, I went through the Queen's physiotherapy program at the time when it was a bachelor's program, and you could select an elective placement. I don't know if that still exists. And actually, you didn't have to do research. So my elective placement was a research placement. And actually, my mentors there, Dr. Brenda Bauer and Dr. Kathleen Norman, kind of encouraged me, said, actually, the way that the physiotherapy education program is going, moving to a master's, there's going to be a demand for people who have a PT degree and a PhD. And so maybe this is something you might want to consider.
Yeah.
But I was determined to practice clinically, yes, and exactly as you said, if I was going to contribute to the profession through research, I really felt like I at least needed to know what it was like to be in that profession.
Yeah.
And so I practiced clinically for a few years, and I think that has benefited me, and I think it Not to say that people can't ask clinically relevant questions who haven't practiced clinically, but for me anyways, I find it helpful.
Yeah.
And then when I was out in practice, and I think physios, I'm not unique in this, physios have mentioned this before, you're practicing and you want to do your best to use evidence-informed practice.
Yes.
And it's certainly when you're first starting out, I think you rely on it more because you don't have the clinical experience to draw from. So you go to the literature maybe to a greater extent. And I just found like I had more questions than answers. So I would go and say, I'd like to try body weight support treadmill training, but for how long, and how do I know where to start, and what percentage of body weight, and how do I know how long to go for, and what speed, and just couldn't find any answers. So I think that's kind of what helped me make the journey back.
I think I was talking with another clinician about a month ago, and we had a similar discussion around how to get involved in research, which I'm going to follow up with you on a question here in a moment. But what he suggested was that it's important to be asking those questions as a clinician, because those questions that can turn into research projects are more apparent to the frontline clinician than they might be necessarily if that same person were sitting in a lab trying to dream up what to research next. You see it on a day in, day out basis, and that's perhaps where those sort of seeds can be planted.
Yes, I agree. I think too, there's always the challenge of speaking different languages, the researcher and the clinician, but I think if you can find that common ground, then absolutely the answers or the questions that the frontline clinicians have can be shaped into research projects. Oftentimes, what has to happen though is like, that's a great question, but I need to answer these three first before I can reliably answer the question you have.
Yeah.
I just was at a workshop. I volunteer with the Canadian Physiotherapy Association. We had a workshop on knowledge translation, and Dr. Catherine Sibley, who's at the University of Manitoba, gave the talk, and she said that, quoted the number 17, which is the number of years it takes for something in a research paper to make it to a frontline kind of textbook.
That's depressing.
That's not such a good number.
No, it is not.
I think we need to do better speeding that up.
Right.
But I think that gives you a sense of how much needs to be done before it can be applied clinically. But absolutely, I think this idea that the CIHR is also promoting is this integrated knowledge translation. Bring the clinician in at the beginning of the research project, get their input at the start, and throughout the whole project. And that's not a lot of time. The busy clinician doesn't have a lot of time, but I think the role of a clinician can be so much more than just, you're the person who's going to recruit for me.
Yeah.
So get them involved at the beginning so that you can shape the question so that at the end you have an answer people are actually going to need and use.
And also, I think that it's important that on the clinical side, not just the research side, but on the clinical side too, hey, try some stuff. That's where the innovation is happening. People are trying to figure out, hey, what can I do to better impact and create better outcomes for the person that I have in front of me right now? And that's the idea of evidence-informed rather than evidence-based practice. So we say, okay, I've read some literature on this. There's some research out there. It doesn't cover everything that I want to do, but I have this great set of clinical expertise. I know the person who's in front of me. I'm going to try some stuff. I'm going to innovate a little bit. And then maybe later I can take out my experiences and communicate with the research community to help really drive maybe a more poignant or pointed research question later on.
Absolutely.
Yeah.
I think there's value in that. Here was this study, and here's what I drew on and what I added to it in order to apply it. And I think I even encourage people to go one step further, write all that down, write down all your rationale. And if you're taking outcome measures anyways, pre and post, do that as well. And then eventually it could accumulate, or there's avenues within certain clinical journals that you could write a paper just about that. And maybe that's not something you might have the time to do, but you could find somebody to team up in an academic institution to help you do that.
Part of it, I think, is Headspace as well. I think that in the same way that we encourage all of our clients and ourselves and hopefully all of humanity to think of ourselves as athletes, which I do think is, fundamental to who we are as humans. I think that we need to think of ourselves as also being just the type of people who contribute to science. I mean, that is the type of attitude that we need to have in people coming out of entry to practice physical therapy programs and any sort of scientifically based clinical practice. So that we can encourage better participation, because goodness knows we need more people working on the research, if not wholly in the research, in our field. Yeah,
exactly. Think about it. Yeah, it's participating.
Yeah, that's just the type of professionals we are. We need to have those types of attitudes. How we create that, we gotta work on that. But
I think too, I've received. I think researchers need to be open to that as well, because I've given a few talks, and I gave a talk at Winter Center, and a clinician asked a question at the end of my talk that actually has generated a new research question or a new project for us. So I was giving a talk about this idea of our rhythm perception, so the ability to hear the beat in a music. That varies widely across people, which might actually relate to whether or not you enjoy dancing or not. Rhythm perception, maybe you don't enjoy dancing quite so much. But there's a lot of work out there about using rhythmic cues, which I think clinicians have done long before there were studies verifying it. Just play a metronome and ask people to match their footfalls. We're interested in whether or not, if your ability to perceive a rhythm is impaired after stroke, which we know we've done some work to show that that is the case, does that then limit the benefit that you'd have from using a metronome cue? But then a clinician asked me, said, this is great, but how would I assess that? Because I have the clinical test I give with a computer to patients. I shouldn't say clinical test. I have a laboratory test that I give to patients to quantify their perceptual ability, but you don't have that on the front line. And so when they asked me that, right in the middle of that discussion, there was other clinicians in there problem solving about how might you do this, which was great. But then it benefited me as a researcher, because I thought, well, actually, that's another project. And we could maybe develop an app to do that and then test it. So I think by having researchers get out into the clinical community and really don't give the regular talk you give at a research conference. Really talk about, here's my work, here's how I think it might be useful for you. Now you tell me how you think it might be useful for you.
Let's have a human discussion.
Yes.
So that was my next question. So how do you get that translation out into the community in a way that's effective? Is it giving talks? Is it writing articles? Is it I don't know, going on Dancing with the Stars to talk? Like what do you think? What's been your experience so far?
I think it's all of the above. As I mentioned before, that workshop that Dr. Sibley gave, it made me realize that actually knowledge translation itself has become its own research field. Because the truth is, we just don't know right now. The majority of what researchers do is what's called dissemination, which is only a small piece of knowledge translation. So I write an article or I give a conference presentation, and that's it. I disseminate the work, but research has shown that doesn't actually help clinicians.
It is disseminated.
That's exactly. I just threw it out there. I'm done. Wipe my hands off and go home.
Part of the problem with that approach is not on researchers at all, though. It's not a researcher's problem. It is also, again, as thinking of as clinicians, as thinking of ourselves as people who we're just the type of people who contribute in the research side of things. It also imbues a responsibility to get out there and empower ourselves with the knowledge of what's going on in the world of research. It's a two-way street, and I think that the responsibility lies in both hands. So dissemination is not, that being your responsibility is such a one-sided word, right? It really has to be a two-way street, and I think the attitudes on the way of all of us as clinicians also really matters there.
Yeah, I agree. I think it's definitely a two-way street. I think there's certainly a lot of researchers would take that approach, is that that's not my responsibility. I disseminate, that's what you pay me to do, so to speak. But I think I would take it one step further and encourage people to think that, yes, it has to be a two-way street, which means researchers do have to engage a little bit further past that stage. And if you think about, my work is funded by taxpayers' dollars or by donors' dollars. So I have a responsibility. I'm using taxpayers' money
Yeah.
to do this research. They need to derive some benefit, and if their clinicians aren't actually using that information, then the taxpayer doesn't get return on their investment.
Yeah.
But I think it has to be a two-way street.
Yeah.
You're right.
Yeah, the clinician needs to get out there and do their side. Yeah.
Yes, yeah. So I think talks, yes, but I think you're just as you said, it has to be a human discussion. I like that. It can't be just I'm going out there to depart knowledge on people. I think it needs to be a different mindset around why are we getting together to talk.
Yeah.
And maybe that would help as well.
That's all. Yeah, as you say, I could see that being an area of research for someone's PhD thesis. So, given all this stuff, connecting clinicians to research and doing things that are innovative and unusual and trying to contribute in some way to make the world a better place, which is, I guess, what we're all trying to do. I don't guess, I know. What is the thing that you think that clinicians or even researchers can do, anyone who's a professional in our field can do right now to distinguish themselves and better contribute to clients and the world in general? What do you think it takes? And I'm not talking about be an innovative person or come up with the next best thing, but just little habits. Like, what do you do each and every day that you think really contributes to your being, an award-winning researcher?
Oh boy, that's a big question. I think being curious.
Yeah.
Always having that curiosity, or I guess that drive of okay, I'm doing it this way.
Yeah.
And this applies to everybody. I've been doing it this way, but is this the best way? Is it still the best way?
Yeah.
Has something new come along? So I think being curious.
Yeah.
Which I guess also relates to the term that we like to use for physio programs of being a lifelong learner.
Yeah. I would agree with that.
Yeah.
Go ahead.
Oh no, and I think physios have this compassion and empathy, and recognizing that I saw a TED talk, one of my favorite ones by Ken Robinson, where he talks about diversity, but thinking about it not from the evolutionary biological perspective, but diversity in talents and a diversity in intelligence, and that there's not just one way to move, there's not just one way to think, or there's not one way to live your life, but having appreciation for diversity, and that's what helps the world advance. So I think being open and inviting for diversity, I think also is probably a characteristic of the physiotherapy profession already.
Just expose yourself to stuff. I would follow up on that curiosity and that appreciation for diversity, though, with action. So it's not just being curious, it's about taking action on that curiosity. And that is something that I think happens on a little bit on a day in, day out basis. There's never this so-called magic moment of epiphany. It's just little things that you're doing each and every day to create something out of, perhaps your curiosity or your exposure to an interesting and innovative idea. And I think, once again, that goes back to how it is that we look at ourselves and what it is that we're capable of. So I cannot talk enough about that, and sort of add that piece into what I think is universally accepted for people who want to be high performers. That curiosity piece, I hear that again and again and again and again, and then I would compound that with, hey, take some action on it. Not big action, a little action every day.
A colleague and a friend of mine, Jackie Sadie at Western University, who's I'm sure people watching this will know who that is.
She's awesome.
An expert in the orthopedic and manual field. She said something that stuck with me is when she goes to conferences now, she doesn't go to the ortho talks. She goes to the neuro talk or the COPD talk. She goes to something that's way outside her field of practice because she feels that she gets more, like she learns more from that, because the ortho stuff she'll probably be exposed to it or read it anyways, but at a conference you have the opportunity to branch out a bit. Yeah. I've been applying that myself. So when I mentioned I went to the talk yesterday with TBI where Adam Van Koeverden was speaking, I went to a talk on sleep disturbances. Yeah. Now, as a physio, you might think, well, I don't treat sleep, I don't do anything with it, but it opened my eyes. This amazing is that our memory gets consolidated in sleep, and not just declarative memory, not just the stuff you studied at school that gets consolidated in sleep and moved over into long-term storage, but also implicit learning, so motor learning happens, that consolidation happens. So the experience that I had with my daughter, she's learning how to skip a couple of summers ago, and she's going to the park, and she was, doing the 1, 2, 3, and then her feet would get caught. And it's like, oh, then she'd do it again, 1, 2, 3, and her feet would get caught. She'd do this over and over. She goes home one night, goes to sleep. We go back to the park the next day, and the first time she skips, she does 12 in a row.
Yeah.
So something happened in that sleep.
Yes.
Made me think, oh my gosh, that was curiosity. But now, as a clinician might think, wow, sleep is important. And if I'm trying to teach my patient a new motor pattern, so we want motor learning to occur, maybe it is worthwhile to ask them, how are you sleeping at night?
Oh, yes.
Rehab. And it's not just learning. I mean, recovery happens in our sleep as well. So this idea that, okay, maybe I should know something about sleep.
Yes.
At least enough to know if sleep's disturbed in my patient, maybe I should encourage them to go talk to their doctor about it.
Yes. Yeah, no, that's excellent. I love that.
So,
I asked
Stevie's advice. Don't go to your field of practice when you're at a conference. Go to something else.
the number one thing we can do to improve our own health, this is the lesson from today, get a good sleep.
Yes.
It's a fundamental health habit, though. I put it right up there with exercise, eat well, sleep,
Absolutely.
and some sort of reflective practice, and have a good group of friends. That's the other thing.
Yeah. The person who gave the talk was Dr. Catherine Wiseman-Hates, and she said something too that was interesting. She said neuroplasticity, which is how we learn, how we change. Sleep is the price we pay for neuroplasticity.
Okay.
So,
all right.
great.
Well, you know what? I like neuroplasticity. I'll take some more of that. So a good night's sleep, if I can, it almost seems like a double benefit. It's hardly a price.
Yeah.
Okay.
Yeah, sure.
I love it. Okay, good. So what are you working on right now that's sort of exciting you to get out of bed in the morning?
Yeah. The dance project. So as I mentioned, trying to get this project up and running where we actually measure what happens in the dance class instead of pre and post. So that's exciting for me.
Yeah.
And then I touched on a bit as well. We're also looking at measuring rhythm abilities and seeing whether or not that relates to your rhythmicity of gait as well as your responsiveness to the treatment or intervention that's using rhythm as a cue. So I think those are the two things that are exciting for me at the moment.
Yeah.
I kind of see it as we're just at the beginning. So I think that's what's exciting for me is that there's a whole bunch of different possibilities to branch out into.
Cool. How can people reach you if they want to know more about what you're doing, your research, your projects? How can people get you?
Sure. Well, if you go to the University of Toronto and the Department of Physical Therapy, each person on the faculty has a profile page, and all my contact information is there. So I have email, I'm on Twitter, and we have a web page specific to our lab.
Okay.
That's probably the best way.
Okay, cool. So I'll put some notes in the video notes about the University of Toronto Department of Physical Therapy webpage to direct people there as well for you. Are there any other thoughts that you'd like to express either to clinicians or researchers or just to the general patient population or anyone out there in the world to sort of send us away with today?
Oh gosh.
I didn't send that question to you in advance, did I?
I think just the themes that we talked about is this idea that think of it more as what can each of us do. Don't think of it as strictly in a researcher's domain or a clinician's domain, but think of it as more of a human conversation. And when people come together, that's when the good stuff happens.
Yeah.
And then, as far as the rehab, it's interesting. Persistence. That's been a theme on Twitter. Mm-hmm. She persisted, and that was a theme yesterday in the talk of just showing up and being persistent, sticking with things, and being present each day. I think that's more than half the battle is being persistent for a patient, as well as for a clinician and a researcher. And then the last thing that I would suggest is that. Finding something that you're excited about. This innovation award, which is wonderful and it's great, but kind of came out of me looking for something that I enjoyed, which was dancing. And so that's kind of funny to me that I started gaining momentum in my research when I started to involve something that I loved and found enjoyable.
Yeah.
So.
Awesome. Thank you so much, Dr. Kara Patterson, for being with us today. And I really appreciate your thoughts and your perspectives, and appreciate the work that you're doing to make both our profession and the world a better place to be in. So really appreciate it, and we'd love to sort of follow up with you to find out more about how that research progresses in the coming years. I know that there's, I'm sure, going to be some exciting things come out of your work. So thank you so much for joining us.
Yeah, thanks for having me.
Great.
Bye.